WEBCAST is now starting. All attendees are in listen-only mode.
Hi, good afternoon. Today is Friday, September the 4th. I'm Donna Will, Professional Development Coordinator for the Developmental Disabilities Administration. We welcome you to the Friday series of DDA updates. Our presenters for today include Bernie Simons, the Deputy Secretary for DDA, Dr. Karen Harvey, psychologist, author, trainer, Dr. Kenneth Feder, PhD Epidemic Intelligence Service Officer for the Centers for Disease Control and Prevention, Patricia Sestoki, Director of Programs for DDA, and Valerie Roddy, Director of Fiscal and Operations for DDA. Before we begin, I'd like to go over a few things about the webinar. All participants are in listen-only mode. There are two options for listening to the webinar by computer or smartphone. There's a handout for this webinar, and you can find it in the handout section in the panel to your right. They can also be emailed upon request. We will be recording the webinar and posting the YouTube link on the DDA website. Questions can be typed in the question or chat box in the webinar panel, and we'll answer those towards the end of the presentation. So now I'd like to introduce Deputy Secretary Simons. Good afternoon.
Good afternoon. Thank you, Donna. And I just want to take the opportunity to thank everyone for their continued support for attending our webcast. I trust that they've been informational and that, that we have good interaction with a number of questions. I also want to wish everybody a happy and safe holiday weekend. And it's just amazing to believe that in the blink of the eye, we started the COVID in March. And now we're in September. God knows where the time goes. Today we're going to share several updates from Dr. Feder on the DDA outbreak guidance. We're going to talk about Appendix K and any updates that we got from CMS, Amendment 3, and then obviously it's an honor to have Dr. Karen Harvey. Many of you already know her, and she does a lot of stuff about trauma-informed care, and we're fortunate to have her as someone who lives in the Baltimore area, so that it's like having to get somebody from across the country to have an expert in your own backyard. Again, I want to be able to say that our highest priority is everybody's health and safety and well-being, and we want to continue to be transparent as we have been, and we'll continue to move forward with our system. Donnie, you're about 2 slides behind me. Okay. And so I just want to bring to everybody's attention that the U.S. Department of Health and Human Services announced that is extending Medicaid and CHIP relief funds. So the deadline to apply for phase 2 is now September 13th. So that's another 9 days from now. So hopefully with the link here, providers and individuals will take advantage of sending in those applications. Next slide. So yesterday, I sent out a letter that basically said that we are delaying the full implementation of LTSS, that in moving to a fee-for-service. I want to make sure that again, as I've said on previous webinars, we need to take this very slow. We need to make sure that we test, that we make adjustments as we've been doing that. I want to thank the people who are in the pilot group that started last December for their time and giving feedback and the interaction with the DDA staff. I want to make sure that we continue to mitigate concerns that are held by the people who are in that work group and for the pilot and what we see. And I want to also make sure that the LTSS system can handle additional providers billing. I mean, it's one thing to be able to say, does the system work? I think it's a second issue to start taking a look at what does that look like as the volume of providers and who are billing for individuals in their agencies, et cetera, and can the system handle all of that traffic that will be there. So again, we're going to be doing more live testing, before we get into moving forward, we want to make sure that the functionality between LTSS Maryland and the federal MMIS system, Medicaid Management Information System, is fully, before it's fully implemented, is working. I want to thank the additional 6 new providers who expressed an interest in coming in, and as we would be expanding the pilot. And as you can see, we will not be pursuing legislation. We did do legislation last year that authorized DDA to conduct a group as a quote-unquote pilot, as a transforming from our legacy PCI system into LTSS. We will expand that with 6 agencies who have volunteered, and we will not do legislation in 2021 that will mandate that the DDA change its transition from a prospective payment to a fee-for-service. I can't emphasize that enough. We need to make sure that the system is working and that people will be able to bill and the system works. One of the areas that has come up a couple of times, and people have talked about, well, if the LTSS system doesn't work, that means I won't get paid. That means I won't have income to pay salaries for my staff and my agencies, etc. Recognize that we have always gone on record, and I believe that my staff have talked about this a few times on a few webinars and in some work groups, that we will continue to pay prospective payment, so that if you put your claims in through LTSS and MMIS next, and then you only get 80% of your claims, you're short 20% of the revenue you thought that was coming in, that's why we're giving you the prospective payment. And then at some point in the future, we will settle up with the amount of money that was used from that advance payment, which is what our prospective payment is. So I want to make sure that no one it gets hurt financially. No one, obviously, because this is a shift. This is a shift for the providers. It's also a shift for people who are in services, because when we get into the LTSS, and as we talk about different amendments, and as we've gone through an evolution in the past few years, we have responded to individuals, families who basically have said we would like the opportunity to have different types of services, etc. We've gone from about 30, 31 to about 42 or 43 services in subsets. So again, we want to have a flexible, person-centered, family-oriented system. If you think of our areas about self-advocacy, self-determination, housing, families, and employment first, those are the 5 areas that are extremely important to everyone in our system. If you did not receive the letter yesterday, you can see on slide 5 here that there is a link that goes to that memo that went out yesterday. So that's where we are.
Bernie, 1 second, please. Donna, the slides are not showing, not matching. Can you just give me a permission to show my slide, please?
Yeah, 1 second.
Sorry, guys. I just want to make sure. Okay, Donna, what do you see?
Electronic visit verification.
I'm sorry. Do you see my full screen? What are you seeing?
Yeah, and I see your background, which is the trees.
Oh, okay. Hold on a second. Let me see if I can move to.
So while you guys are working through technical difficulty, let me just say that, I want to make sure that there's an additional time for providers to prepare for a transition. We will do this slowly, and we will make sure that the systems are functional with what the expectations are for you enter the time for a service for an individual. There's the good linkage between LTSS Maryland and MMIS. and the payments are processed. That's number one. Number two is the volume issue. You know, to test 35, 50, or 100 people as we continue to move forward to get to the number of people we have in total supports and services. I just want to make sure that our system, and we continue to work with Medicaid, since they are the owners, for lack of a better term, of LTSS, and we do work closely with them to continue to move forward and making sure that everything is good. So, are you ready yet, Patricia and Donna?
I'm just working on. I'm sorry. What do you guys see on the screen?
Patricia, so what we're seeing is, I think we see the Appendix K, the Deputy Secretary's update with some notes underneath.
Okay.
So I think we need to go back.
Yeah, sorry about that. I'm just trying to figure out.
Go back to what's Donna got.
Maybe we'll just pick up where Donna left off. She was on slide 5, I believe. Yeah.
Go
So maybe
ahead.
we'll pick up there.
Are we on 6 or 5?
You're going to 6 right now. No, okay. I finished that. You're going to 6, please.
You should see 6 on the screen.
Yep.
Okay.
So Appendix K, there has been, and I apologize to everybody for, we've been better than this in a previous webinar, so I apologize. So on Wednesday on the 2nd, CMS approved the revisions to Appendix K, and basically you'll see what's there for the retainer payments is going from 18 to 30 days, which is excellent. And we obviously want to make sure that, and I think, Valerie, you want to talk about the slide a little bit, slide 7.
Sure, yes. So let me roll back. I think our slides are a little bit, no.
Go back one.
Gotta go back. Sorry.
Go back one. Go back to 6.
Yeah, 6. So anyway, so yes, Bernie is correct. So one of the good news is that CMS approved Maryland's request to increase the retainer days from 18 to 30, which was really good news. So that does two things. It increases the retainer days for both residential and meaningful day services. It also increases the retainer hours for personal supports from 102 to 120. So DDA is modifying these PCIs to reflect these changes. However, we have a timing issue here. We know that many providers, in fact, DDA has received about 2,500 error updates just since the end of mid-August. So we also recognize that many of those error updates were requests to correct situations where the retainer days exceeded the 18, which then impacted the provider's ability to input future attendance. So we are working, DDA is taking care of that. We are going to try to resolve all of this on our end so that providers do not need to take any action whatsoever. Once we issue the second quarterly payment, as we do some more reconciliation, if providers see a discrepancies, please let us know, because we are going to try to do this as much through an automated system so that providers do not have to resubmit any error updates. Next slide. So this slide just shows the change and in the 30 days. So it's 30 days for example, the meaningful day services, retainer days will be paid up to 30 days at 80% of the normal and usual rate. That is true for personal supports, and for supported living and community living, it is the retainer days are good for up to 30 days at 100% of the normal and usual rate. Next slide.
Our next slide talks about our Amendment 3. And as some of you joined us this week, on yesterday, we shared the proposed Amendment 3 for all the 3 waivers. And the DDA will consider all input that we received to be applied to all 3 waivers. So there, you don't have to sit there and write a response for each of your waivers. So what you have on the slide in front of you is just describing what is the period of a public comment, which is from September 1st through September 30th. You also will see that there's track changes document regarding the amendment proposals in our website. And if you're going to submit public comment, this is the email to submit it to. And due to the pandemic, we ask you to really consider and sending it via email. Next slide, Donna. This slide pretty much tells you exactly each of the waivers. You can link to it and it'll bring you directly to each of the sections through all the appendices, and it walks you through each of the things that we shared on the webinar on yesterday. Next slide, Donna. This one is just giving everybody a review and a summary of some of the next steps that we have. So we have public comment between now and the end of the month, September 30th. We are going to review all the public comments, input, make sure we share this with the Deputy Secretary, and then we have to share with Medicaid's final review and approval, and our goal is to submit to CMS on November the 1st. CMS will review between November 1st to January, and our proposed effective date is for January 1st. Next slide, please. All of you this morning, maybe about an hour ago, we should have received a memo from a Deputy Secretary in reference to the Detailed Service Authorization tool. It is a new tool that we're using, and we're hoping that that tool helps streamline the communication between the CCS and the provider. And through this process, we're hoping to reduce the amount of revisions and clarifications and back and forth between provider, CCS, and the DDA, so that we can make sure we have a smooth approval process. And we are going to be provided a training on September the 11th. At 1 o'clock, and so you should have received the memo, the actual tool, and also the registration for that webinar. I know some people request at least 2 weeks notice. We're trying to get this out as soon as possible and then be able to provide hands-on support and direct communication. So in that memo, it'll have my email address. If you have any questions about the tool or anything else, please make sure that you let me know. Next slide. I'm turning it over to Bernie.
So we give updates on where we are with people who have tested positive and unfortunately people who have passed away. So let me go through the data that we have as of yesterday, September 3rd. So the South region has 249 confirmed positives for people we provide supports to, 70 negative, and 7 are pending results, and we've had 17 individuals pass away. In the East region, there is 36 confirmed, 131 are negative, 8 are pending, and we've had nobody pass away. In the Central region, we have 243 positive, 528 negative, 24 pending, and we've had 18 individuals pass away. And in the West region, we've had 38 positive, 202 negative, 6 pending results, and 3 people have passed away. For direct support professionals, we've had 182 positive in the South, 4 people have passed, 43 in the West, and 1 staff has passed away. In the East region, we've had 7 staff, direct support professionals test positive. And in the Central region, we've had 248 staff test positive, and 2 people have passed away. Next slide. So in our DDA tracking that we presented, obviously the pie chart on the left is staying fairly consistent with the 97% of the people, and then 3% who have tested positive, at a total of 603 individuals. And then the chart on the right basically shows a breakdown by region, and you will see that if you want to study it. It'll be obviously on our website. Next slide. This is where we are with the pie chart showing that there are 38 participants who have passed away of the 603 who have tested positive. And since our last report, we had one additional person who had passed away. And so, I want to thank everybody for all of the wearing PPE, the social distancing, the hand washing, everything that's being done to keep people as safe as possible. And now I want to thank Dr. Feder for joining us today and turn this over to him. Thank you.
Okay, thank you, Bernie, and thank you to everybody for inviting me to join to just provide a brief but hopefully useful update on our recommendations for stopping outbreaks of COVID-19 in homes for people with developmental disabilities. I want to preface this by saying that what we are doing here is we are just updating the guidance that we've circulated in the past with two kinds of updates. The first are updates that we're making to basically bring this guidance into line with the latest CDC guidance. So in other words, CDC has made changes, so we're updating it to reflect changes. And then the second set of changes we've made are basically changes that reflect similar changes that have been made in either nursing homes or other settings that are prone to outbreaks, where we want to try to see folks making the same changes in group home programs for adults with disabilities, now that there is, at least to some extent, greater availability of testing and greater availability of PPE than when I first came to speak to you several months ago. So what I'm going to show is the draft document that will hopefully go out early next week. My screen should be sharing now, so hopefully folks can see that. I'll just talk through some of the key differences from what was in there before, and then hopefully that won't take more than 5-10 minutes, and then take a couple minutes for questions. Okay, so starting with the recommendations for preventing and preparing for outbreaks of COVID-19 in your programs, right? So continuing to limit entry into your homes. One update is, and most homes, I believe, most of these changes, I just want to preface by saying, are switches that people have already made anyway, I think, to most extent. But we want to formalize them just to make sure that everybody knows that we're on the same page. So the first is that previously we had recommended that staff should be wearing cloth face coverings or medical masks, like disposable medical masks or respirators at all times. What we'd like to do now that there are no longer as severe shortages of medical masks, is just to emphasize that staff are healthcare providers, and therefore, like other healthcare providers, when they're at work, they should not be wearing cloth face coverings. They should be wearing medical masks. So that's like a surgical mask or a respirator, an N95 or higher level respirator, or equivalent, like a KN95 mask. And that should be done at all times. And that's just, emphasizing that the requirement for staff who work in group homes for adults with disabilities is generally what we ask of healthcare providers. And that's because basically those masks, which are mass produced, are made up to certain minimal standards, as opposed to cloth masks, which may be bought through various sources and don't have any necessarily standards of quality control. So totally fine for personal use, not great for working in group homes. Okay, this next change I want to highlight has to do with the minimum level of personal protective equipment we're requiring when interacting with residents. Okay, so when providing resident care. Okay, so previously we had recommended that staff wear a medical mask when providing resident care, and that during an outbreak, staff wear medical mask and gloves when providing resident care, and that during an outbreak, staff add a face shield or eye protection. We're upping that recommendation to recommend that staff wear a respirator or medical mask if respirator like a KN95 or N95 is not available, and eye protection. So that means a face shield or goggles. That's the key change whenever they're interacting with residents or providing resident care. So adding eye protection. And the reason we're doing that is because of the really good evidence that wearing eye protection prevents people from contracting COVID-19 because of droplets that land in their eyes. And so what this does is it just ups for all staff the level of personal protective equipment that should be used to the recommended equipment that CDC recommends using for caring for people who are actually known to have COVID-19. So basically we're saying, since we still are having trouble knowing who does or doesn't have COVID-19 because people may be carrying it while asymptomatic, when staff are providing resident care, we want an even higher level of protection. Let's try to use face shield or goggles for all resident care. And we know many programs are doing this already. Okay, so this point is new. And it's just re-emphasizing something that I think most folks are already doing, but I do want to highlight it. So when interacting with each other, in other words, away from residents or program participants, staff should still be wearing a mask and trying to maintain 6 feet of difference. And staff shouldn't be in a shared indoor environment without masks, including on meal breaks. In other words, they should be socially distancing during meals. Ideally, they should be eating outside, eating separately, or in large, spread out, well-ventilated spaces. In other healthcare settings, one of the biggest contributors we've seen to outbreaks of COVID-19 among staff is that staff are extremely conscientious when working with residents, but then they're more casual when interacting with each other. And that can lead one staff being asymptomatic positive, spreading it to several, because staff take off their masks when they're interacting with each other. So making sure that staff are wearing masks when interacting with each other, even away from residents. Okay, residents should wear cloth face coverings if they can. That hasn't changed. Importance of hand sanitizing, that definitely hasn't changed. Limiting recreation activities, trying to promote physical distancing, EPA approved cleaners. None of this is news, so I'm not going to dwell on it. Training on appropriate use of PPE, never a bad time to, redo training for staff on how to appropriately don off, use their PPE. Dedicating staff, we've talked about that in the past. Having a preparedness plan, having a staffing plan, having a healthcare provider. Okay, so this one is new. So if a resident requires medical care unrelated to COVID-19 in the hospital, when the resident returns home, that resident should stay in his room for the next 14 days to the greatest extent possible. And if she leaves the room, then that resident should social distance from other housemates and try to wear a mask in the home if tolerated. So we didn't say this before, but this is actually an important update based on some pretty unfortunate and tragic incidents that have happened in other homes, where basically people have gone into the hospital for other medical care that either wasn't COVID-19 or that was thought to not be COVID-19. For example, falls, something that's not a classic symptom of COVID-19. But unfortunately, because in persons with developmental disabilities, we know less about what the symptoms of COVID-19 might be. And so what we've seen in at least one case was a person who came home from the hospital and then got sick again 3 days later with more traditional symptoms of COVID-19, tested positive, and other people in the home became sick. That person returned to the hospital. And so what this does is it just says if somebody goes to the hospital and they're not diagnosed with COVID-19, they're just there for something else, but they come home, we know that being in the hospital carries some level of risk. And so that person should be on extra precautions when they come home from the hospital, whenever they were in the hospital for any reason, even if it wasn't for COVID-19. Okay, identifying an outbreak. So no changes here. Continue screening folks at your front door if they're going to come into your home. Continue screening all of your residents for symptoms. Immediately testing any resident who has any symptom of COVID-19. Same protocol as before, although we are updating to note that unfortunately, previously there were, quote, go teams operated by the National Guard that could assist with testing. At the moment, that's not the case. That's not in the guidance. So that basically means, you can obtain test kits from your local health department to test your residents and staff. Or you can contract with private provider labs, which we strongly encourage you to do. But either a healthcare provider affiliated with your program has to collect the specimens, or maybe the local health department will be able to help you collect the specimens, but oftentimes they can't. Or if there's no affiliated provider, you can bring your residents to a public testing site using appropriate precautions while transporting them to the site, like wearing masks, wearing eye protection, rolling the windows down in the car to allow ventilation in the car. You can bring your residents to a public testing site to be tested. Okay, so what happens when somebody tests positive? Okay, and we call that an outbreak of COVID-19, whether it's a resident or a staff. So no changes here in terms of reporting. So still make sure you report it immediately to your local health department and to DDA. We know everybody's doing this, and it seems to be going much more smoothly, and we really appreciate the reporting you're doing. Continue to watch for that outbreak number from the local health department to make sure that your report is received. Okay, just a quick update here. So before we said consider testing all residents and staff if someone tests positive for COVID-19. Now we're saying do it. In other words, if somebody in a group home, resident or staff who worked in that group home, tests positive for COVID-19, everyone who worked in the home should be tested for COVID-19 as soon as possible. So basically everybody's doing that already, but just putting that down on paper. There's one exception. If you've already tested positive for COVID-19 in the past 90 days and you recovered, in other words, we know you had COVID-19 and you got better, after you get better, for 90 days, you don't have to be tested. And indeed, we don't want you to be tested, because what we know now is that when people recover from COVID-19, they're almost certainly immune to the disease for 90 days, and they can't spread it to other people once they're recovered, okay? And that's true, we think, for at least 90 days after when they got sick. So sometimes those people will still test positive by PCR because there's some leftover virus RNA in their respiratory tract. Sometimes they'll still happen to test positive, but it won't change any recommendations. You know, they're still free to go about their lives. Once people recover, they're good to go for 90 days. So if somebody in a home tests positive, everybody else who worked or lived in that home should be tested. But the exception is if you've already tested positive for COVID-19 and you've recovered in the last 90 days, you're set for 90 days. Okay, line lists, no change there. Continuing to report everybody, you know, who's tested for COVID-19 to your local health department, and they'll work with you on the formatting for that. Use of personal protective equipment. You know, not a big change here, but really just reviewing the PPE strategies from CDC is always a good idea on a regular basis, and trying to use, you know, more conventional or contingency strategies rather than crisis capacity strategies. You know, strategies that if PPE is more available, we want to be, you know, doing less practices like reuse across residents. So we recognize there are continued shortages, and sometimes those practices are necessary. And so long as they're within CDC guidelines, they're okay. But, you know, CDC has these tiered recommendations of conventional, contingency, or crisis capacity strategies. So if you're doing something that's crisis capacity, you have more availability, you think you can switch to contingency capacity strategies for use, maybe, you know, disposing of disposable products faster, for example, something like that, we encourage you to do so. Keep symptom screening, no change there. Dedicating staff, no change there. Cohorting residents, we've talked about this in the past, but really trying to have a dedicated home where if somebody tests positive, your residents can live to recover, like a recovery home, or if they can't do that, you know, strictly isolating them. Movement restrictions, so, you know, making sure that when somebody tests positive in a home, everybody else in that home is staying home and staying in their room until their quarantine period is over, while we wait to find out if they also get sick. Okay, isolation and quarantine. So this is a very important update, okay? So in the past, we have said, you know, if your staff worked in a home where somebody had COVID-19 and they were exposed to COVID-19, it's not feasible for you to preemptively exclude your staff. So if they test positive, they have to stay home. If somebody tests positive for COVID-19, they cannot work until they've met CDC guidance for recovery. But simply because you were exposed, trying to quarantine people preemptively, we said that wasn't feasible. Now we're updating our guidance to say that there might be certain situations where we think doing that is appropriate. And basically, that's when we find out that a staff person was exposed to COVID-19 without using proper personal protective equipment. In other words, if your staff person was working in a home and they weren't using the minimum level of personal protective equipment, and it turns out that they worked with someone or interacted with someone with COVID-19, and they didn't wear the minimum necessary required personal protective equipment, we're going to recommend that that staff be excluded from work before they even test positive or get sick. In other words, preemptively exclude them for 2 weeks. And if this would create a staffing crisis in a particular home, you can request permission from the local health department not to do it. In other words, we never want to create a staffing crisis. There always has to be minimally adequate staffing in your homes. But sometimes this does happen where there's a PPE deviation and we recognize that a staff was exposed to someone with COVID-19 and could get sick very soon because they weren't following the appropriate PPE precautions. If that happens, we'd like to see that staff person excluded from work before they get COVID-19 because they're at very high risk. And basically PPE deviation means you worked with somebody not wearing a mask, or if the person who you worked with wasn't wearing a mask, you weren't wearing eye protection. So this goes back to the beginning, upping to that recommendation that everybody be using eye protection like face shields or goggles when providing resident care. If everyone's wearing medical masks and eye protection while providing resident care, this should never happen. That's the recommended standard for personal protective equipment. You won't have to be excluding staff preemptively. All other guidance are basically the same, although I encourage everybody to please review the CDC guidance on discontinuation of home isolation for staff in the link here when this goes out. What it's going to say, and then discontinuing transmission-based precautions, just as a reminder, it says that if staff test positive for COVID-19, they need to stay out of work for 10 days after they test positive, plus they need to get better. In other words, if after 10 days they're still sick, they need to not be sick anymore for at least 24 hours. And it used to say 72 hours, but now it's going to say 24 hours. So you got to be out of work for 10 days since you test positive, plus you need to get better. And that is the last change. The end of the outbreak is not the same. It's not changed. So that's everything that I want to talk about. I'm going to stop there and open things up to questions, which I believe Patricia will read to me from the chat box.
Right.
So thank you so much for taking the time, and thank you for everything you're doing.
Thanks, Dr. Feder. Thank you for joining us today. We did have a lot of emails in reference to the handout and the information you were referring to. I've been typing in the chat box that this document is already out on the website, and we just need to update and can't post until we get the final department's approval. If you wanted to add to that as to when are we, I must have like 15 about when can we see this updated guidance, where is it posted, how can they get a copy of it? So Dr. Feder, if you wanted to add to that?
Yep, it's just going through final approval. Our goal is to get it out next week. And, I apologize for folks that I don't have it for you today. The truth of the matter is that I'm actually out on paternity leave, and my colleagues are wrapping things up in my stead. So we hope that will be out to all of you next week. And I'm sure Patricia will let folks know when it does go up on the website and when it does go out to everybody. So you will get the written version, and I just wanted to talk through it all in advance because we only do these webinars every 2 weeks.
So not to cut you off, we're a little short of time. I'm going to read you a couple of questions, and then we'll go to Dr. Karen Harvey. So folks want to know how often do you recommend a changing of the medical mask?
Sure. So it's fine to wear a medical mask the whole time you provide care, basically. So, go into the home and just wear the same mask the whole time you're in there. You don't need to be disposing of it after episodes of care. Actually, the issue where we saw more places where PPE was being extended beyond what we would typically recommend is with use of gowns. So
should they wear gowns all the time as well? Or should staff also, gowns should be worn?
Great question. So they don't need to wear gowns all the time. They certainly don't need to wear gowns all the time in the home. They should wear gowns whenever providing direct care to a resident that requires very close contact. So that means like bathing, dressing, feeding, activities of daily living, and then anything that's going to could create like splashes or sprays, like toileting or bathing or something like that, right? So most of the time, like if you're just entering somebody's room or you're just walking about with them, that's not a situation where a gown is necessary. And I want to emphasize the two things that are really have a very strong evidence base are wearing respirators or medical masks and wearing eye protection. Because the way this virus infects people is primarily through droplets or aerosols that get in your nose, your mouth, and your eyes. And so covering our mouths and our noses, I can't emphasize this enough. I'm sure you've all seen people who wear masks, but it's just below their nose. Covering our noses, mouths, and then having eye protection for our eyes. That's really the key. And that's the biggest change we're saying here is, we already have everybody wearing masks. Let's just try to make sure they're medical masks, not cloth masks. And then let's have everybody wearing eye protection when providing resident care. And hopefully that will cut down on some of these staff exposures and staff infections by using eye protection a little more frequently.
So I am going to allow Dr. Karen Harvey to speak because we're short of time. And so there is a lot of questions that came for Dr. Feder. He is on leave. What I'm going to do is I'm going to flip all those questions to him. He's always very good at responding back to us. And then what I'll do is I will make sure that this gets generated and posted with the guidance that we put on our website, because there are really good questions here and we just don't have the time for today. So I really do apologize ahead of time. So I'm going to thank you so much, Dr. Feder. I really do appreciate it. And then I am just happy to introduce Dr. Karen Harvey. I think some of you guys know, doesn't really know a big introduction, but I just wanted to say to folks who don't know her, who join us for the first time, she is a mentor, a supporter, an advocate. She is a DDA family member for us. She's been very supportive. She's been in the field for over 30 years. She has a master's degree in psychology and is PhD in applied developmental psychology. And she's written several books, some that you may already know. One is a positive identity development, and the other one is on trauma-informed behavioral interventions. And so right now she's doing consultant work, and I'm just happy, very happy that you can join us today. So I'm going to turn it over to you, Karen.
Thank you so much, Patricia. Thank you, Dr. Feder, also. That was illuminating. And thank you, Bernie and Valerie. And I really want to thank DDA. These webcasts have been fantastic. And I venture to say you've saved lives. I mean, and thank you. But the first thing I want to say to everybody, next slide, we're still coping. Yes. And so next slide, the most important thing I have to say is the next slide. Thank you. Thank you for all of you. You have done amazing things. You have bent over sideways, backwards, upside down to help everybody. And it's been magnificent. It's been incredible. You have saved lives. And I don't know how to thank you from the bottom of my heart and on behalf of everybody that you support. Oh my goodness. So next slide, I want to just take a minute to remember all whom we've lost. So many of you have lost people, and I know people we've lost, and take a moment of silence. Honor the individuals we support who have passed and the staff we support, and all of you who have lost relatives, friends, coworkers. My deepest sympathies. Next slide. We want to talk about just briefly, like what you need for you. Give yourself permission to feel. So many of you are doing so much. You're working so hard. You're trying to juggle 10,000 things, but you got to take a minute for yourself. You got to take a minute to feel what you feel. Next slide. Find a space for you. Find a time for you. Self-care. Next slide. I want to go through the Mayo Clinic's recommendations for how to deal with grief. They say give yourself permission to grieve. Write a letter to the deceased person. Journal about positive memories. Remember those memories. Write them down, crystallize them. Talk to someone. Understand those around you are affected. Lend a supportive ear to others. And then prepare for holidays. If you have to celebrate Mother's Day, because you lost a mom. And the other thing that's happening right now is that people are being triggered. A lot of old grief is coming up. So I've been working with some folks. I still do therapy with folks that we support. And so many losses are reemerging. And that's us too. So take a minute, take care of yourself, do what you have to do. Next slide. I also want to say that this is a very tough time, looking at the murders that we've been witnessing. And these have been going on for a long, long time, for many decades. And this is a tough time. If you have experienced racism, if you have experienced discrimination, this is extra tough because these are triggers and it's unacceptable. And next slide. Obama gave a talk about 2 months ago, and he said, you know, people called him up and said, how could this be? We're right where we were in the 60s. What's going on? And he said, no, 2 things have changed. And let's look at that. 1, look at the protesters and the diversity. That's changed. And 2, look at the youth and how the youth are standing up. So this is affecting us as well. Next slide. This creates its own kind of trauma. And post-traumatic stress disorder, which I talk about all the time, is a continuum. You can have all kinds of responses you're not even realizing. No one is at their best right now, right? My friend was saying that we should use 2020 as a curse word. So we should be saying, like, what, the 2020? Are you 2020 and kidding me? Because it's such a horrible year. And we're all a little traumatized. So next slide, I've talked before about the trauma. We may be super vigilant, really focused, overly focused on things, and you don't know why you are so obsessed with certain things. That's a symptom of trauma. Or maybe easily exploding. That's a symptom of trauma. Or maybe disconnecting. Next slide. What we want to really look at is giving yourself a break. To everybody, if you can, take a deep breath in. That means you're alive because you're still breathing. Take a deep breath in and release. Really deep breathing and totally releasing the breath, a practice of Qigong, is very important when you start to stress. And release. And Yumi Sakagawa says, sometimes it's okay if the only thing you did today was breathe. Lower your expectations. You may not be functioning at your best. No one is. And I called this still coping with COVID because I've been doing this coping with COVID talk and everybody expected us to be done when now we're looking at so much longer. It's a marathon, not a sprint. And that affects you. Next slide. We feel like we're entrapped, right? Next slide. So the human brain actually needs socialism to socialize, not socialism. That's another agenda. But the brain is wired for 2 things, right? First, and this is according to Lieberman, who's a brilliant neurologist, first to engage and to meet your physical needs, to eat, to sleep. But then the second drive that the entire brain organizes around is seeking social connection. So right now is a really hard time because we're so isolated and it deeply affects us. And Eisenberger has a number of studies showing the pain of social exclusion. And guess what? They got married. Isn't that nice? I didn't know that. I just found that out. But so the folks we support are very isolated now, and it's really tough. And then we're isolated. And so we have to all give ourselves a break. Give yourselves a minute. Next slide. Eleanor Roosevelt says, you can gain strength, courage, and confidence by every experience in which you really stop to look fear in the face. Where she said this, she's dead now. You are able to say to yourself, if you can, I lived through this horror, I can take the next thing that comes along. So don't underestimate your strength. You lived through this, you lived through 100 other things. It's time to believe in yourself. And next slide, it is time to congratulate yourself. Pat yourself on the back. Oh my God, you DDA people are incredible. Providers, you guys, how are you doing it? I don't know. I weaseled out of my position a while ago. I'm so sorry, but you're amazing. You need to take a minute and congratulate yourself. Next slide. There are gifts of COVID, but it's not exactly Christmas. Slide after that. Next slide. There are more gifts than we realize. It's given us a minute to reflect. Next slide. It's given us more sleep, but it's hard to sleep, right? And then we have strange dreams. So what's happening is our subconscious organizes reality and creates constructs or little boxes that we put our thoughts in, and we're able to understand things. But it's upside down, it's topsy-turvy, it's crazy. Our subconscious is saying, what? And so it's organizing itself and trying to make sense of itself while you sleep. Because our conscious mind that's trying to plan and execute things is moving slower than ever, having more difficulties because we don't have the foundation of a subconscious that knows what's going on. You usually go to work, you usually do this, you usually do that. It's all upside down. And the sad thing for everyone is that it keeps changing. Okay, now we have the new normal, but now we're coming back. Now we're going home again. Now we're over here. Now we're over there. Now we have to change. Okay, now we need eye guards. And it's not easy. Next slide. It's a great time to reflect. So my friend used to tell us how much she hated her husband. We would have girls' nights. Girls' nights is, by the way, the key to staying married. I'm hoping my husband doesn't hear that. He's downstairs, but it's the truth. I think he's already guessed it. You get together every couple of months, you drink, you say everything you can't stand about him, and then you survive. But my one friend, she would go on and on, like she couldn't stop herself. And then she'd talk all the time about how horrible her husband was. She's like a type A, go, I'm doing this, I'm doing that, go-getter. And her husband was kind of, a homebody, staying home, not really interested in doing much. And she just made us all crazy. We thought we were going to have to set up a GoFundMe for a good divorce lawyer because we couldn't hear it any longer. But about 2 months into COVID, she said, you know what? I'm really appreciating Dave. He's been really taking care of my son all this time. And, he's kind of a good cook. All of a sudden, she's appreciating the poor man. All kinds of things like that are going on. There are positives. There are moments. There are gifts. They're not the gifts we were looking for, but there are gifts. Next slide. And there's also resilience. I am amazed at how resilient people are. I am amazed at so many provider agencies that I've been working with and so many people I know and friends of mine who are just making it work, who are just connecting with people who are amazing. 3 elements to resiliency that I believe. We have optimism, engagement, and creativity. Next slide. Being an optimist is everything. So there was a study done. They had people, 3 groups of people, and they journaled. The first one journaled about what was positive in their lives. Like, I had a nice lunch today. I talked to a friend. I got some work done. The second one journaled about the reality, positive and negative. I had a nice lunch. I talked to a friend. I did some work, but then I saw I had a flat tire, and then I got a bill I didn't want to pay, right? They just write the reality. The third group journaled about just what was wrong. So I had a flat tire, and I had a bill I had to pay. After just a matter of weeks, the people who were journaling only the positives actually ended up feeling more energy, more enthusiasm, being more focused, and reporting optimism about their life. The people who just reported the reality actually got less optimistic. Interesting, right? And the people who just journaled about the problems became more pessimistic. Now let's think about ourselves. What do we think about the problems? We're not thinking about what's right. Oh, you don't have to think about what's right. Oh my God, what do I have to fix today? What do I have to worry about? And you guys, I know you have a really long list, and I know it's not easy. But taking a minute to think about what's right, to appreciate yourself and what you've done, to appreciate the small gifts. So for years, Oprah has been telling us to do gratitude journals. And every night I would say I was going to do it, but instead I'd be drinking a glass of wine and watching my Netflix. I used to say watching Netflix and chilling. And then somebody told me to stop saying that because that wasn't happening. But, so now what I do in the morning, when I get up, I write down, get in that little window before I start drinking. Try to do my little journaling about my optimism. Just write down what you appreciate. It makes a giant difference. Next slide. Celebrate. Celebrate what you've accomplished. Celebrate anything you can celebrate. This is so critical for our mental well-being. It's so easy to focus on the negative. When you schedule a celebration, even of the smallest thing, Joe didn't put a hole in the wall for 3 months. Let's have a party. Or anything. You lift yourself. You revive yourself. with the celebration. Schedule them and have them spontaneously too. Figure it out. Next part, next slide, next part about resiliency, engagement, playing, doing. You know, I always feel guilty when we're playing, but I read this wonderful book that play is actually really important for our neurological health. Every time you play, you rewire your brains, and adults should be playing. Good news, right? Good news for my Candy Crush habit. I'm embarrassed to admit I'm still playing that. Next slide. There's a beautiful book by Stuart Brown called Play, and he says play can become the doorway to a new self. So in homes, we should have people playing all different games, new games. I know a mom that has 2 children with a disability and another child, and everybody was just fighting every day. And she decided that she would set up a new obstacle course every week in the backyard and then have races every day. And all of a sudden they're playing and they're doing different things and they're not fighting as much. How can we play more? Really critical way to get our brain into positive new grooves. Next slide. Creative living. You've already done this, all the workarounds. Not being creative as much as living, doing outside of the box. It's okay to let go of the way we did things. And you guys are champions of that, so I don't need to say any more. Thank you. Next slide. Again, congratulate yourself. And remember, this too shall pass. This too shall pass. Next slide. I'm going to show you again. I showed it in the community of practice talk, the butterfly. If you go back and forth like this is an EMDR technique. The minute you're starting to really stress about something, tap with your arms crossed and breathe. Think about what you're stressing about. Breathe and imagine yourself just letting it go. Do that for 10 minutes and you'll go back to it and you'll have a different view. Works every time. And finally, the last slide. Daisaku Ikeda says, those living in an age of crisis must become the pioneers of a better age. And there's Nelson Mandela. There's someone who endured racism, who endured imprisonment, entrapment, a change of reality, and he prepared himself during that time, came out and changed the world. The gift of COVID is it is a time to reorganize. But I love this quote because Daisaku Ikeda, a great Buddhist scholar, says, those living in an age of crisis must become the pioneers of a better age. And what I feel is that you who work in this field of caring for people who have been marginalized forever, who have been invisible, who have been ignored, you are the greatest humanists on every level, whatever level you're working on, whatever you're doing, you are the humanist. And this age needs humanism. So, you know, there's an organizational concept that I've been talking about in my trauma-informed management trainings about leading from any chair. You are the leaders of our new world because you're the people who have put people first in just the work you've chosen, in what you do every day. So I want to thank you again and say, please, you stand up, take care of yourself, move forward, lead those around you to be the humanists that you are, because you're the ones we're counting on. Thank you so much. Done.
Karen, thank you so much. I got goosebumps. I love you. I adore you. Folks on the chat are saying, bringing you back. You are awesome. You truly are just remarkable. And thank you for those positive words of encouragement to keep us going. You are awesome. Thank you. And I really do appreciate you being a part of our family and supporting us. You rock. You rock. Thank you. There's lots of questions on the chats, not specifically about your presentation, but most likely there are about DDA and retainer payments and specific questions about the transition to LTSS. I know it's a holiday weekend and I know we only have 1 minute left. I will tell you this, we are going to be providing additional guidance and communication. My goal is to share these questions here with Valerie and Bernie, and we're hoping to everyone who registered for today's webinar, we can give you the answers back. There was lots of questions for Dr. Feder. There's lots of questions of Valerie in reference to retainer payments. I just would like to end today with that positive energy that Dr. Harvey has given us, and really on behalf of the DDA, thank all of you who truly are mentors and for choosing this field and giving the voice to most vulnerable people and working with people with developmental disabilities. Our goal is to get it right. Our goal is to partnership with you. Our goal is to work together. And while sometimes we agree to disagree, we all have a common purpose and a vision. So please enjoy your wonderful holiday weekend. We'll make sure that your questions on this chat don't get put aside, and we will get back to you for those who register for today. So thank you and have a wonderful holiday weekend.
Thank you.